Sir, we are live, sir.
So a very good evening and a warm welcome to all our attendees. We are back with a fresh edition of the very popular webinar ESI Case Capsule. As is customary, I would first invite the patron and the president-elect of Endocrine Society of India, who is also the patron of the ESI Case Capsule, Professor Sujoy Ghosh, to share his opening words with us before we enter into the knowledge-based part of the program.
Thank you, Shomik, for giving me this opportunity. At the very outset, I would like to welcome all of you to this new season of ESI Case Capsule, which is very popular with the students and which I feel helps you brush up your clinical skills, your clinical knowledge. After all, endocrinology is a clinical subject wherein you need to have an analytical mind in terms of the way you actually go about dissecting the many layers of mysteries of any clinical case. So I would not waste any further time and hand over the session back to Dr. Somi to take things forward. I hope particularly the students enjoy this session and do provide your feedback in terms of what you think we could do on behalf of ESI to make the program even better. Thank you very much.
Thank you. Thank you, Professor Ghosh, for mentioning in brief what this event is all about and for your words of encouragement for our very bright students. So today, as our moderator, we would like to invite the very popular Professor J.P. Shahu, who is also the head of the Department of Endocrinology at JIPMER, Puducherry, to present the case. Along with Dr. J.P. Shahu, we have his student, Dr. Anita Sebastian, will be the presenter today. And to deal with the layers of the case, to dissect the case, to analyze the case, to answer questions, give comments, we have three bright students in endocrinology from across the country. I would like to invite Dr. Suyash Gupta, who is a resident at MS Ramaiah Medical College, Bengaluru. Along with Dr. Suyash, we have Dr. Amulya Reddy, who is a postdoctoral trainee at Gandhi Medical College, Hyderabad. And as the third student panelist to take us through the discussion, we have Dr. Harshini Sompalli, who is a postdoctoral resident at Apollo Hospitals, Jubilee Hills, Hyderabad. Without further ado, without wasting further time, I would hand over the virtual podium to Dr. Jayaprakash Shahu to teach us over the next 40-45 minutes or so regarding today's case in endocrinology. Over to Dr. Shahu.
Thank you, Dr. Somik, for kind introduction. So, a very good evening to all. And at the outset, I would like to thank Dr. Sujay sir and the whole ESI for giving me the opportunity. So, today we have a very interesting case of precocious puberty. So, I would like to invite our student, Dr. Anita, to start the presentation.
Good evening, everyone. Can I share my slides now?
Yes, please.
Are my slides visible, sir?
Yes, go ahead.
Yeah, please go ahead.
Good evening, sirs, and good evening, colleagues. Today I'm presenting Decoding Precocious Puberty, the importance of a stepwise approach. My moderator is Dr. Jayaprakash Sahu, sir. So we have a 4.5-year-old boy coming from Trichy, who's brought by his mother with complaints of development of pubic hair since the past 4 months and increase in the length of the phallus since the past 4 months. So the child was apparently normal till 4 months ago when his parents noticed development of pubic hair around the root of the phallus. Initially, they were fine hairs, later became thick and darkly pigmented. Parents also noticed an increase in the size of the phallus, which was gradually progressive with nocturnal erections. Parents do not report any increase in the size of gonads. There is no history of any development of axillary hair, acne, or body odor. Mother noticed that child was gaining height. He was previously in the middle of the assembly line. Now he is at the back. There is also history of change in mood with aggressive behavior and anger outbursts.
Okay. So, Anita, can you summarize? So, from this slide, what is happening to this boy?
So now we have a 4.5-year-old boy who was presented with history of development of secondary sexual characters in the form of development of pubic hair and increase in size of phallus from around 4 years of age. And mother has also noticed an increase in the height. There is height acceleration also. So we are dealing with the case of precocious puberty. Parents, however, have not noticed any increase in the size of gonads. So we are probably dealing with the case of gonadotropin independent precocious puberty, because in gonadotropin dependent precocious puberty will usually follow the normal sequence of pubertal development, and in males or in boys, gonadar or increase in the size of the gonads is usually the first sign of pubertal development. So here, since it is not following the normal sequence, gonadotropin independent precocious puberty is more likely possibility. However, gonadotropin dependent precocious puberty cannot be completely ruled out, because history can be unreliable and parents cannot usually make out the increase in size of gonads.
Okay. So we can ask other students like Dr. Harsini, can you tell what are the difference between peripheral and central precocious puberty?
In central precocious puberty, sir, we see sequential progression of the pubertal changes. That is, in a boy, it will start with enlargement of gonads, followed by pubar, penile enlargement, and then scrotal enlargement and rugosity. Whereas that is gonadotropin independent, we will not see this gradual progression. There can be increase in the penile length without any increase in the testicular volume.
Okay, then
Um,
any other difference? Anybody else? Suez, Amulya? Anita, can you tell what are the other differences between peripheral centers? Because other than whatever we have discussed, any other points?
Sir, normally
Yes.
the most, hello, sir. The most important thing is the difference in the sequence of development will be maintained in central precocious puberty, because it is dependent on the activation of the normal HPG axis in gonadotropin dependent precocious puberty, where it is not dependent on the activation of HPG axis in peripheral precocious puberty, and the sex steroids are activated irrespective of the activation of the HPG axis. And also there will be other findings features like very early onset of puberty is usually seen in gonadotropin independent precocious puberty, whereas gonadotropin dependent precocious puberty is usually later in onset. And heterosexual precocious puberty, that is precocious features of secondary sexual characters developing in against the gonadal or chromosomal sex of the patient, will be seen only in gonadotropin independent precocious puberty, whereas in GnRH dependent precocious puberty, it is always isosexual precocity.
Additionally, in the history and clinical examination, you can get also some clue related to the etiology.
Etiology
Okay,
of
okay,
precocious puberty.
that will discuss later. Okay, go ahead.
So coming to the history to identify the etiology of precocious puberty in this patient, there is no history of any headache, visual disturbance, altered sensorium, uncontrollable laughter or giggling, suggestive of any intracranial space occupying lesion or hypothalamic hamartoma, which can present as central precocious puberty. There is also no history suggestive of any meningitis or encephalitis, or history of any irradiation to the head, which can also lead to central precocious puberty. There is no history suggestive of hyperpigmentation of the body, episodes of abdominal pain, vomiting, or loss of weight, suggestive of any salt wasting type of congenital adrenal hyperplasia. There is no history of skin lesions, bony deformities, or fractures, suggestive of McCune-Albright syndrome. And there is no history of any mass in the abdomen or scrotum, which could be secreting either androgens or HCG. And there is no history of any recent weight gain, stria, or poor wound healing, which could be seen in conditions where there is co-secretion of cortisol and androgens, as in adenocortical tumors. No history of any drug intake or exposure to any creams or ointments, which can point towards an exogenous androgen exposure. Slide, sir. So, coming to the perinatal and developmental history, child is first born of a non-consanguineous marriage, born full term by cesarean section done for non-progression of labor. His birth weight was 2.9 kgs and he cried immediately after birth. There is no history of any hypoglycemia, vomiting, failure to thrive, or hyperpigmentation of genitalia or body in the perinatal period. Child attained age-appropriate developmental milestones and there is no history of any developmental delay. Now he is studying in LKG. Shall I go ahead, sir?
Please go ahead. Go ahead.
Past and personal history. Child had one episode of GTCS associated with fever at the age of 1.5 years. He is not on any chronic medication. He takes a mixed diet of approximately 1,300 kilocalories per day and 15 grams of protein per day. Coming to family history, the child's mother had 2 spontaneous first trimester abortions. And the boy has a younger sibling who is a girl, 1.5 years of age, and there is no history of any early puberty in the family, no history of any adults with short stature, no history of sibling deaths or neonatal deaths, and there is no history of any DSDs in the family.
Okay, so what is the importance of history of consanguinity and family history in case of precocious puberty?
So family history of precocious puberty can be there in patients who have GDPP or in GIPP. And GDPP, it can be due to mutations in loss of function mutation in MKRN3 or DLK1 gene or kisspeptin receptors. In MKRN3 and DLK1, it is a paternal inheritance. Also, familial also there can be GDPP in other conditions like neurofibromatosis or tuberous sclerosis, where there can be gonadotropin-dependent precocious puberty. Additionally, in GIPP, family history is important because it can be seen in positive family histories present in familial testotoxicosis, and also in conditions like congenital adrenal hyperplasia, where there can be a positive family history of precocious puberty.
Okay. Okay. So, Dr. Suez, can you tell what is the importance of consanguinity in a case of precocious puberty?
Yes, sir. As Dr. Anita already mentioned, after that, I'd like to mention, like in CAH, there is this, sorry, yes, in CAH, like being autosomal recessive. So there are increased chances of consanguinities there of the gene implication being happening in the offspring. So it becomes important. So
Okay, so in this case, like whatever history you have discussed from that information, can you tell what is the etiology, probable etiology in this case of precocious puberty?
yes, sir. Considering this is a male, and that too at the age of less than 6 years. In a male, it has been told that around 50% of the cases can be organic in cases of CPP, central precocious puberty. We'll have to specifically think about any tumors in the CNS, as already mentioned, things like there is a history of seizures as well. So that increases at the back of the mind, I'm thinking about the hamartomas, if they can be there in this patient, and we'll have to
Okay.
work up regarding.
But what is the one important point against central precocious puberty in this case in history? Whatever we have discussed so far.
Absence of testicular volume, sir.
Very
That-
good. We don't know how much will be reliable in this history, because this is the information we are collecting from parents. But what you have rightly told, this is a very important point. Okay, the gonads are not enlarged according to parents. So can you tell what are the causes of peripheral precocious puberty where you can get increase in gonadal size?
It can be
Very-
seen.
let them tell. Amulya, can you tell?
So peripheral precocious puberty with increase in testicular volume can be seen either in CAH with testicular adrenal rest tumors, Leydig
Okay.
testotoxicosis,
Mhm.
tumors, uh, hypothyroidism, McCune-Albright syndrome.
No, hypothyroidism, you will not get features of hyper and features of testosterone excess, no?
Yes, sir. There will
That
not.
is like, that is pseudo puberty, because the gonads will be enlarged because of myxomatous material deposition. So gonadal size will be increased, but there won't be any increase in height, or there won't be any increase in phallus size. There no feature of testosterone excess. So that is not like true precocious puberty. That is actually pseudo puberty. So in peripheral precocious puberty, yes, you are told, like one is CH with adrenal rest, and other two are like testostoxicosis and AC secreting tumor. So why you will get increase in gonadal size in testostoxicosis and AC secreting tumor? Because in CH, in adrenal, with the adrenal rest or gonadal tumor, the testicular increase in testicular size will be asymmetry. So because you will not get symmetry, like same size of adrenal rest in both side. And second thing is tumor usually unilateral. So that you can distinguish clinically. But the difficulty will be in case of AC secreting tumor and testostoxicosis, in which case like the gonadal size will be bilateral increase, but it will be not as much as in central precocious puberty compared to the testosterone level. But it will be in between, like it is more than a classical case of peripheral precocious puberty and lesser than the central precocious puberty. So what is the possible cause why you are getting increasing gonadal size in AC secreting tumor and testostoxicosis, like bilateral, like equal increase in gonadal size? What is the possible explanation?
There is
It,
Ah.
it could be because of the increased LH, increasing the intratesticular testosterone, that having an positive, that is proliferation of seminiferous tubules, and that causing the increase in testicular volumes.
Okay, good. So that is important. So whether it is because of like testostoxicosis, where there will be increased testosterone production from the Leydig cell, or because of AC secreting tumor, which ACG, in that case, ACG will basically act on the LH receptor. So in both cases, there will be increase in intratesticular testosterone production, which leads to the proliferation of like seminiferous tubules, where like spermatogenesis happens, because 80 to 90% of like maybe more than that of the testicular size is composed of seminiferous tubules. So increase in those components of testis, so obviously leads to the increase in testicular size. Okay, Anita, carry on.
So from the history, we have a 4.5-year-old boy who is a firstborn of non-consanguineous marriage with uneventful perinatal and early childhood history, presented with pubic hair growth, increased phallic length, and height acceleration for the past 4 months, with no reported increase in gonadal size. There is no history suggestive of any intracranial mass lesions, gonadal or abdominal mass, skin lesions, or salt crisis. However, simple virilizing form of CAH cannot be ruled out. Only salt crisis, salt wasting form can be ruled out.
So what is the okay, before going to this DD thing? So already I think Dr. Suez has raised the importance of seizure in this case. So is it clue we're dealing with central precocious puberty in this case? You have mentioned, no? I think some
One
past
episode
history
of
of
fever. One
yeah.
episode of fever was there at 2 years of age. Less during an episode of fever, there was one
Okay.
seizure.
So that means most likely that must be the case. Might be the episode of febrile seizure, I think.
And there is no recurrence of seizure afterwards. And the onset of precocious puberty symptoms have started only since the past 4 months, whereas the seizure does not have temporal correlation with these events.
Okay, fine. So we'll go to the differential diagnosis at the end of history.
So at the end of history, my differential diagnosis, first I would like to keep GnRH independent precocious puberty. In that, I would like to consider CAH of CAH, simple virilizing form of 21 alpha hydroxylase will be my first priority. 11 beta hydroxylase deficiency can also present in the similar way without salt crisis, but that is a much rarer entity. And androgen secreting tumors of the adrenals or gonad would be my second differential diagnosis. Third, I would like to keep HCG secreting tumors. And fourth, I would like to keep McKeown-Albright syndrome, even though from the history, I don't have any history of any skin lesions or bony deformities or fractures. But sometimes in McCune-Albright syndrome, initial presentation can be precocious puberty, and bone deformities may not be identifiable clinically. Fifth, I would like to keep testotoxicosis. Familial testotoxicosis is unlikely in this case because there is no family history. However, sporadic de novo mutations also can happen and can present in this way. And the last study, I would like to keep other forms of virilizing congenital hyperplasia, adrenal hyperplasia, like where there is resistance to the action of glucocorticoids or decrease in the activation of cortisol, as in glucocorticoid resistance syndrome and cortisol reductase deficiency. And I would also like to keep GNRS dependent precocious puberty also as my DD, because from history, we cannot reliably rule out gonadal enlargement. So causes of GNRS dependent precocious puberty like hypothalamic hamartoma, suprasellar tumors, and arecanal cyst also have to be kept in mind.
Okay, any student wants to ask any questions related to differential diagnosis? Amulya, Arsini, Suez. I think Dr. Srushti also, I think one of our student. I'm not sure.
One doubt regarding the if the history is only 4 months since they are giving the history, and they are saying the standing in the line from mid to the back. So has the height increased that much in the past 4 months? Yeah.
Okay. Okay. Please.
That is the history that they are giving. Like there is definite increase in the height from middle of the assembly line to the back of the assembly line at present. So height acceleration is significant according to the mother. But whether they have noticed it at the time of onset of acceleration, I'm not sure.
Okay. So actually, if you see in this case, suppose, okay. So in this case, if you see, we are not getting any clue regarding the etiology at the end of history. Maybe you will get some clue in the examination. Before going to examination, we can analyze a little bit like differential diagnosis. Here you see, so testotoxicosis, okay, that is not a common diagnosis, very rare diagnosis. And and the gonads anyway is not enlarged. And McCune-Albright, at least there is, according to parent, there is no obvious skin lesions, but bone deformity obviously may or may not be there. So now the question is, acid secreting tumor, usually it won't be hidden. By the time patient will come, there will be some picture of the primary tumor, like you can get. The more here the actually other than the, because he's presenting at the age of 4 years, definitely we can keep central precocious puberty, also one episode of seizure, though it has happened during puberty. Other than the central precocious puberty, the other two important diagnoses we can keep is small Leydig cell adenoma. That can be missed clinically. Even parents will not able to notice. Sometimes clinician also can miss. Only an ultrasound can detect. It may be around sub-centimeter, like 8 millimeter, 10 millimeter, 12 millimeter, very small lesion. Unless you will examine very meticulously, you can miss. So Leydig cell adenoma can be one DD definitely in peripheral precocious puberty. And when it comes to CH, obviously it won't be a case of salt closing, but it can be simple fertilizing. But the definitely the history is not classical, like in classical fitting in simple fertilizing CH, because CH there will be androgen production even before birth. It is not a postnatal phenomenon. So because there is a deficiency like cortisol, so increase ACTase, so ACTase will stimulate adrenal gland. So even in the day one of birth also, if you evaluate, you may get increased adrenal size. But that's difficult to interpret because newborn itself, they will have like bigger adrenals. So anyway, so in the case of simple fertilizing CAS or whatever the like saltosing CAS, or if it is virilizing, so there will be in testosterone production before birth. So it is not like it has come at the age of 4 years. So Dr. Shreyas has asked, actually, that is a very good question. So maybe the increase in testosterone production leading to the increase in phallic size or pubic hair, like appearance of pubic hair, that has become like more recently, so that parents have noticed. But definitely, unlike like lyric cell adenoma or central precocious puberty or other cases, this CS is a prenatal phenomenon. So there might, in this case also, there might be increased production of testosterone if this is a case of CS since birth. So it's not like it has come at the age of 4 years, but that has the symptoms has become prominent. That's why maybe that has indirectly, like for that reason parents gave attention. But this would have been this is if this is a case of simple blazing CS, then the testosterone production must be there since birth, not before, not birth, before birth. So, but here anyway, so we are not sure at the end of history. So if you see at the age of 4 year, maybe central precocious puberty, maybe small lyric cell adenoma, maybe simple building CH. But myconal, right, usually they present a little early. And anyway, and testosterone and glucose resistant, those are not very common diagnoses. And SE secreting tumor, by the time they will present, they will have some obvious clinical feature of the original, like the primary tumor. So in this case, that is not there. Okay, anyway, we'll go to the examination and investigation, then we can get the clue.
So coming to examination, vitals, pulse rate is 102 per minute, normal volume and character, no radial or radiofemoral delay, and all peripheral pulses were equally felt. Blood pressure is 87/41 millimeters of mercury in the right upper limb in supine position, which is less than 50th centile. Respiratory rate is 18 per minute, and the child is febrile at examination. There is no pallor, icterus, cyanosis, clubbing, edema, or lymphadenopathy. There is one caffeole macule of less than 0.5 centimeters on the left shoulder with smooth borders, and there is no obvious bony deformity on examination. Coming to anthropometry, his height is...
So, Arsini, can you tell what the difference between capulate spot of myconalbride versus neurofibromatosis?
The borders,
Please,
we see.
please tell.
Yes, the borders which we see in caffeolate spots, those are smooth bordered, sir. Whereas in neurofibromas, we see sharp borders. It is called as coast of Maine and coast of California.
No, in which case border will be smooth, in which case border will be regular? Anita?
In
neurofibromatosis, usually the borders will be smooth, sir, and in McKeown-Albright syndrome, the borders will be irregular. And that is known as coast of Maine in McKeown-Albright syndrome and coast of California in neurofibromatosis.
And second point, difference?
Usually it will be respecting the midline in McKeown-Albright syndrome, and the bony deformity will usually be on the site of the skin lesion in McKeown-Albright syndrome.
Okay, fine. Go ahead.
Coming to anthropometry, his height is 116 centimeter, that is +2 standard deviation score. Height age is 6 years, and weight is 19 kg plus 0.6 STS. Weight age is 6 years, and MPH is 164 centimeter, that is coming at the 10th centile. Target height range is 156 to 170 centimeters. Arm span is 117 centimeters, and upper segment to lower segment ratio is 1.07. From this, you can see that there is increase in the height. There is advancement in the height, especially when compared to mid-parental height. Coming to SMR, this testicular volume is 3 to 4 cc on the right side and 3 cc on the left side, and there is no palpable testicular mass on examination. SPL is 7 centimeters, and pubic hair is stage 3, axillary hair is absent. Systemic examination, per abdomen, there is no hepatomegaly and no mass palpable. Nervous system examination, there is no ptosis or squint. Extraocular muscle movements are full in all directions. And visual acuity and field of vision is normal. Fundus is not showing any papilledema or optic atrophy. Cardiovascular system, S1 and S2 are normal, no murmurs or added sounds. And respiratory system, bilateral normal vesicular breath sounds are heard. So from the history and examination, summary is we have a 4.5-year-old boy born out of non-consanguineous marriage, presented with appearance of pubic hair and phallic enlargement since 4 years of age, with no history suggestive of any intracranial mass lesion, salt wasting crisis, skin lesions or bony deformities, or gonadal or abdominal mass, and no family history of precocious puberty. And on examination, his height is advanced of +2 standard deviation score with height age of 6 years. An SMR shows prepubertal testicular volume on both sides, 3 cc on left side and 3 to 4 cc on the right side, with SPL of 7 centimeters and pubic hair stage 3 with no axillary hair. Shall I continue, sir?
Yeah.
So from after examination, I would like to keep the possible diagnosis of GnRH independent precocious puberty. And here I would like to consider the etiology of congenital adrenal hyperplasia of simple virilizing 21-alpha hydroxylase deficiency as the first possibility. 11-beta hydroxylase deficiency is less likely considering that the blood pressure is on the low normals side. But sometimes 11-beta can present without hypertension also. And adrenocortical neoplasm secreting androgens is still a possibility. And like I told, testicular tumors can sometimes be clinically not evident and can miss on palpation, can be very small. So testicular tumors like Leydig cell tumor is also a possibility.
So in examination, like what finding you have got, so that you have now keeping like peripheral precocious puberty as the first DD, not central one?
Because the testicular volumes are, in first we expect gonadarch in central precocious puberty. So here the testicular volume is not in pubertal level, it is less than 4 ml. So that is pointing towards a peripheral cause of precocity as the first possible diagnosis, sir.
Okay. And clinically, there is no abdominal mass.
There is no abdominal mass.
Okay, so like that, we cannot rule out like any intra-abdominal, either adrenal or any other SOL. Anyway, so now basically we are focusing on the peripheral precocious puberty. Still, we don't know what we are dealing with, whether it is a adrenal neoplasia or it is adrenal hyperplasia or it is a small testicular adenoma. We don't know. Okay, we'll go to the investigation, then we'll get the final answer. Okay, we'll go to the investigation. Yeah.
So basic routine investigations showed hemoglobin of 13.6, RBS was 81, creatinine was 0.23, sodium and potassium were normal, 137 and 4.56, calcium was 10.2, phosphorus was 6.2, and alkaline phosphatase was 320. X-ray showed a bone age of 9 years by GP Atlas. And coming to hormonal investigations, thyroid profile was normal. ATM cortisol was 4.45, which is low normal. And plasma ACTH measured by Imulite is 155.4 picograms per ml. ACTH stimulation test was done and it showed a peak cortisol that was 4.97, which is subnormal, 4.97 microgram per deciliter. So we did 17-hydroxyprogesterone. Basal 17-hydroxyprogesterone came as 68.90 nanogram per ml, suggesting possible 21-alpha hydroxylase deficiency. And his FSH was 1.77. LH outside when it was done, it was 0.28. And at our institution, it was 0.2. And GnRH analog stimulated LH was peak LH was 13.37 after giving leuprolide 20 microgram per kilogram at 3 hours. And testosterone at baseline was 20 nanogram per deciliter. And after 24 hours of leuprolide stimulation, it was 49.91 nanogram per deciliter. Beta HCG was normal. So here we have evidence of, because GnRH stimulated LH is more than 5, there is evidence of GnRH dependent precocious puberty also. And also we have evidence of 21-alpha hydroxylase deficiency from hormonal investigations, sir.
So what are the like positive findings here?
So
So if it is peripheral precocious puberty, then why you are getting high LH value?
So causes of peripheral precocious puberty sometimes can late become converted to central precocious puberty because of prolonged sex steroid exposure can prime the HPG axis, and that can lead to activation of the HPG axis, GnRH pulse regulator. So it can lead to central precocious puberty after some time.
Okay, so in spite of high ACTH, so why we have not got the information on the hyperpigmentation from the history?
His skin color is dark complexion, sir, but it is comparable to that of the parents. So there is no history suggestive of any hyperpigmentation according to parents, and on examination also it is comparable to parents.
Yeah, so this is very important because if the child is fair, that is fine. If child in the like they're like constitutional like their dark complexion, so in that case you can miss like mild to moderate hyperpigmentation because of simple realizing CS. And important thing is because the baseline 1700 progesterone itself is 68.9 nanogram per ml. That means this is a case of classical, most likely classical 28 hydroxy. So classical, there are two types, simple parallelizing and short fluing. So most likely is a case of simple parallelizing classical variety. Still, in spite of there is absence history of hyperpigmentation and no history of any adrenal insufficiency in the past, still it is possible. So that is the message from this case. Okay, we'll go ahead.
We did a non-contrast CT abdomen, and it shows bulky adrenals bilaterally, suggestive of adrenal hyperplasia. And other investigations like MRI brain and cella, which was done from outside, showed partial empty cella and no intracranial space occupying lesion. Ultrasound scrotum also did not show any testicular mass, and USG abdomen and pelvis did not show any intra-abdominal tumors or mass. Bone scan was also done to look for fibrous dysplasia. There was no fibrous dysplasia in the bone scan. So we went ahead because of the possible diagnosis of 21 alpha hydroxylase deficiency of simple virilizing type. We did hotspot mutation screening of CYP21A2 gene, and the child came compound heterozygous positive for two mutations. One that is I2G mutation, which is known to cause salt wasting classic CH with less than 1% enzymatic activity, and I172N, which causes simple virilizing type because it retains 1 to 2% of enzyme activity. So as is known about the phenotype-genotype correlation in 21 alpha hydroxylase deficiency, when the child has compound heterozygous mutation, the less severely mutated allele the phenotypic manifestation will be according to the less severely mutated allele. So here, since he is compound heterozygous for a salt wasting and a simple virilizing kind of mutation, his presentation is like a simple virilizing CH. So final diagnosis is gonadotropin independent, GnRH independent precocious puberty converted to GnRH dependent precocious puberty due to simple virilizing congenital adrenal hyperplasia due to 21 alpha hydroxylase deficiency. Diagnosis. And
Okay. So, what are the like causes of what are the causes of virilizing CS, Amulya?
So virilizing CH in could be because of 21 alpha hydroxylase deficiency or 11 beta hydroxylase deficiency, and very rarely, 3 beta hydro HSD2 deficiency.
Okay. Anything else? Only these three DDs there. So can you keep 3 beta deficiency, 3 beta SS deficiency here as a differential diagnosis?
there is no genital ambiguity in 3 beta HSD2 deficiency in boys usually present with some genital ambiguity. So that is not there.
Yeah. So basically, you should know keep virilizing CH in male and virilizing CH in female. So in 21 hydroxylase deficiency, 11 beta hydroxylase deficiency, and 3 beta acid deficiency, and POD deficiency. In all four conditions, there will be increased androgen production. So all four causes will cause some virilization in a girl. But when it comes to male, so 3 beta SSD and the POD deficiency, though there is some virilization, that is for a female, but for a male it is actually under virilization. So when it comes to male, so virilizing CS mean only two, that is 21 and 11. So if 11, obviously there won't be any salt crisis, rather there will be hypertension leading to hypokalemia. Sometimes there will be uh, paraparesis or quadriparesis because of hypokalemia. So in a male, don't tell 3 beta or POD deficiency as a cause of virilizing CS. Actually, we should tell only 21 and 11. Okay. So another interesting thing is in case of like genotype phenotype correlation of like 21 hydroxylase, as we have already discussed. Like in this case, when there is two different genetic mutation, and one is a milder one, another one severe one. So the manifestation will be milder one. So that's why here patient has presented as simple virilizing CS. Okay, so next we'll go to how to treat this patient. So Arsini, can you tell here where the testosterone is coming from in this boy?
Testosterone is the predominantly it is from the adrenals because of the 21 hydroxylase deficiency, enzyme deficiency.
Okay.
The pathway of the steroidogenesis is directed towards the formation of testosterone via the androstenedione.
That is fine. So Suez, are you agree with Arsini, or you want to add anything else?
The 21 alpha hydroxylase, like
No.
in both,
What is the source of testosterone in this boy now? Is it only adrenal or additional testosterone is coming from somewhere else?
it is both, sir, adrenal as well as testicular tissue, because
Very good, because now the child has
it is-
entered peripheral to central precocious puberty. So now testosterone is coming from both. So you have to treat so that testosterone production should stop from the both adrenal and gonads. You cannot target only adrenal. Though there is, you can argue if the testis is the source of testosterone and are supported by increased LS in the general stimulation test, then why testicular size is not increased? Maybe we can tell patient was having peripheral precocious puberty predominantly, recent entry to central precocious puberty. That's the only possible explanation in this case. Otherwise, we cannot tell ki one end we are telling coronal size is less than 4, and the other side we are telling LH is more than stimulated LH is more than 5. But that is the only possible explanation. But remember, so when it comes to treatment in this boy, we have to treat both. So we have to give two drugs, one for gonad, one for adrenal. Okay, go to the treatment so that we can finish in 2-3 minutes.
So the child was started on oral hydrocortisone at 10 milligram per meter square per day in 2 divided doses to treat the simple virilizing CAH. And to treat the GDPP, we have started on leuprolide 3.75 milligram IM once monthly. And at 3 months follow-up, there is no progression of any pubic hair growth or penile size. The basal LH was 0.2 milli-international units per ml, and 3-hour post-leuprolide LH was 7.2 milli-international units per ml. 17 OHP was 28.4 nanogram per ml at follow-up, and serum electrolytes were normal. So we have increased the dose of hydrocortisone to 15 milligram per meter square per day, and leuprolide depot was changed to 11.25 milligram per in once in 3 months, with a plan to monitor the height velocity at 6 months and bone age at 1 year.
Okay, so here we are giving two treatment like steroid supplementation to decrease testosterone production from adrenal, and GnRH analog to decrease the production of testosterone from the gonads. So how to monitor? How will like sure you are giving appropriate dose of both the drugs?
Clinical
17.
Please go ahead.
We have to monitor for clinically for SMR at every visit, every 3 months, and for height velocity, and also bone age has to be measured to see whether the precocious puberty has come under control. Additionally, we have to monitor the 17-OHP levels to see whether the congenital lateral hyperplasia is being treated adequately, along with blood pressure and serum electrolytes to see the adequacy of treatment of CAH.
And in addition to blood pressure and sodium potassium, because that is mainly in the, like, when you are supplementing both glucocorticoid and mineral corticoid, even people give both in simple paralyzing case of CS, even though there is no salt losing crisis, because if you give low dose of mineral corticoid, the requirement of glucocorticoid will be come down, because glucocorticoid will have side effect on the growth and weight of the child. Anyway, so in this case, we have started with only hydrocortisone. Later, we'll see if we will not able to control 700 progesterone with hydrocortisone, we may add low dose of mineral corticoid. So in both type of classical case of CS, simple bed losing and short losing, you can add both. But only thing, short losing case, you will require you have to give more mineral corticoid. And the target of 700 progesterone is 5 to 10 nanogram. So here 28 still high. So we have to either increase hydrocortisone or to add mineral corticoid, because you cannot go on increasing hydrocortisone, particularly beyond 50 milligram meter square, because there will be decrease that will affect the child growth and the weight. And regarding the dose of leprolide, so some people just monitor only SMR, and some people in addition to SMR they monitor one of the 3 parameters. Like you can take basal LS, you can take stimulated LS, or you can take basal testosterone. Out of 3, you can take any one. So or 3 together, it is depending on your Lois. So if you are taking these 3 parameters, so LS should be basal LS should be pre-pivotal, and testosterone, basal testosterone should be pre-pivotal, and the post leprolide LS should be less than, like 5, 4.5, 4, like different cutoffs are there. Basically, stimulator should be in pre-pivotal, that is less than 4, 4.5, 5, like that. Okay. That's all, no? Okay. Thank you. So now I think we'll hand over to Dr. Mohan so that he will take care of the quiz.
Yeah, good evening, sir. Thank you, sir. It was a very excellent quiz. Dr. Saumik, would you like to comment on the question, what you call the case presentation? Yeah.
No. We had a wonderful case presentation. Heartfelt thanks to both Dr. Sahu, Dr. Anita, and all our student panelists today, Dr. Suyas, Dr. Amulya, Dr. Harshini, for wonderfully teaching us over the last 45 minutes or so. Without further ado, I would hand it over to Dr. Mohan for the exciting part, the exciting finale to this event, the quiz. And of course, we have prizes for the top 3 winners. Over to Dr. Mohan to explain the rules and regulations and take us through the questions.
Thank you very much. So I will just share the screen. I request Sham also to help me if screens are, because some Mentimeter also we are planning to have.
Yes, sir.
So, is the screen visible?
Yes, sir. You can go to slide mode and show the QR code and wait.
It's coming. It's coming.
Yeah.
Is it coming? The screen is coming?
Yes, sir. Yes, sir.
Okay. Thank you very much. Thank you, ESI. Thank you all for joining today. So we'll go directly to the quiz. We have 5 minutes left. So we'll try to get the topics and all covered. Those who listen to today's capsule, it will be very easy for you, cakewalk for you. Those who have not listened but are keen to learn, you are please welcome to again participate and learn. If you are winning cash prizes, that is very good as well. So let me explain the rules of the quiz. There are 10 questions, multiple choice questions, and it will be dynamic in nature. It will be via a Mentimeter. So this is the QR code which has been created especially for this. It has not been shared anywhere. So I request all of you who are available in this program, relate the program, live program, to just share, just scan this QR code.
Yeah, sir. Let's put on the screen for like two minutes. Let people join. Yeah.
So we'll have to really understand that these are all basic questions and these are all based on the cases we discussed today. And these are all practically relevant also. So as we go, we also understand that there is cash prizes in store for you like the last years also. So So I'm very grateful to the ESI central leadership led by Dr. Kaushik Pandit, Dr. Sujay Ghosh sir, Dr. KVS Harikumar, and all the senior people, including Treasurer Dr. Santosh, for having graciously agreed for this. So we'll just wait for 1 minute or two so that those who have joined will understand that we are live now.
More people are joining, sir. Yeah, we'll wait.
Yeah. As we talk in, I'm just expressing my gratitude to all of the ESI members also for having joined us today, as well as for listening. Special thanks to our master brain, Dr. V. Srinagesh from Hyderabad, who has been a guide and inspiration to me, as well as many endocrinologists, as well as to the ESI Pediatric Endocrine Task Force, which of course I am been convening, and we have got a lot of members. Please write to me if you are interested to participate in any collaborative activity. We'll be having more research topics as time goes. So as of today, it is a general ESI program. So we'll just have more episodes of ESI case capsule done. So we'll listen to all experts, stalwarts. So the quiz rules have been explained here. So we'll just wait for 1 minute more. Tell me when it's right to go ahead, Dr. Mr. Sham.
Yes, sir. As of now, 43 have joined. More people will join, sir.
Okay. So all our students or all our endocrinologists also, we are not able to understand that, right?
Yeah, they have to give their full name, sir, for us to get. So
okay.
Yeah.
So the students over here, they are also welcome to participate. Okay.
Yes. Sir, by the end of this thing, sir, whoever wins, they have to drop in their names to us in the question box.
Yeah. So how will we know whether they are from institutions? So they have to give right back to us with their institution details as well.
Yes,
so we'll see how far, because the best 3 will be selected. So if at all you don't meet the students category, maybe you have to get consolation only. Okay.
Yes, sir.
So decision of the ESI team is final. Quizmaster as well as the ESI team is final. Okay.
We'll wait for half a minute, sir, before we start.
Yeah. So you'll be knowing how many have joined, right?
Yes, sir. 55 now.
It's done via this Mentimeter. So you can scan this QR code. It's easy. I also tried the demonstration. It's quite easy to get in.
Sir, I think we can start with the demo question, sir. Yeah.
Yeah. So if there is, we'll just start the demo. You have still 30 seconds more. So if you are late to join, you tell your friends to also join. Okay. So let us start. Let us do demo question. Okay. So it's a very simple demonstration. So just to find out whether you are all alert. Yeah. So please just answer this just to check whether you are on track. What is the capital of India? So if you feel it's Hyderabad, it is A. If it is Kolkata, it is B. C is for Delhi. It's actually New Delhi again. And D is Mumbai. So just for your, maybe your alertness, it's not for your IQ. So have they answered? 30 seconds. You have to just help me, Mr. Sham, with the timing.
Yes, sir. I will give you the cue, sir. Yeah. Sir, you can go to the next question, sir.
Yeah. 1 second. So somebody is telling me it's not got the questions. Okay. Yeah. So we'll start now. So again, I'm putting the QR code for those who have missed it. The only first question will have the QR code again. So question number 1, according to the 2022 guideline for central precocious puberty, which of the following pelvic ultrasound findings is cited as a supplementary diagnostic criterion? It is not a standalone criterion for puberty onset in girls. So options are in front of you. If you want me to read, I can read. Option A, option B, option C, and option D. Very long options have been mentioned here. So you can read option A. The size of the length of the uterus is mentioned there. Volume is also mentioned. uterine length more than or equal to 5 to 6 centimeter, first option. Ovary volume more than or equal to 2 centimeters cube is there. Option B, uterine length more than or equal to 3 to 4 centimeter. Ovary volume more than or equal to 4 centimeters cube. Third option, uterine length more than or equal to 3.5 to 4 centimeter. Ovary volume more than or equal to 2 centimeters cube. Or is it D, fundus to cervix ratio less than or equal to 1:2? So are we done? First question?
No, sir, we have to wait. Yeah. I'll give you the cues.
Yeah, because actually the question, the stem are very long. So
yeah.
So we can see 15 seconds more maybe.
No, I'll tell you, sir. Yeah. Done, sir. We can move on to the next question.
Okay. So now onwards, no QR will be displayed. So already you have scanned, already you have understood. So question number 2, a 5.8-year-old, 5 year 8 months boy presents at a testicular volume of 6 ml, a peak LH value of 10 IU per liter, no neurological symptoms. So we already discussed similar case here today. Most appropriate choice among these options. Is it option A, MRI brain imaging mandatory? Option B, MRI brain only if symptomatic? Do you want to repeat the LH after 6 months? It's option C. Or do you want to do an MRI brain only if there is a testicular asymmetry? So you have time. Mr. Sham will tell me when the time is done.
Sir, you can move on to the next question, sir.
Okay, thank you. So question number 3, 6 year 5 months or 6 year 6 months girl, TANUS B3, pubic hair 2, bone age 9 years, basal LH 0.8, FSH 4.1, estradiol 75. So we have done a tryptophan stimulation. LH rises to 4.8 IU per L, and then FSH is also 7 IU per liter. MRI brain is done, it is normal. So how do you interpret this in the best way? Is it A, is it a premature thelarchy only with high baseline FSH? Is it B, central precocious puberty, GnRH dependent early phase? Is it C, peripheral association with incomplete feedback maturation? Is it option D, GnRH independent puberty with secondary pituitary adaptation?
Sir, you can move on to the next questions.
How many have joined? I think we have already told that after the end of the question 3, maybe we should know the trend, what is happening.
Yes, sir. I'll show you.
Should I stop sharing?
No, it's okay, sir. I'll do the screen shares. Yeah, you can stop the screen shares.
Okay, so for the first 3 questions, we have got some response. So I'll just share the screen, stop sharing the screen. Meanwhile, Mr. Sham, just tell the leaderboard right now.
1 second.
I hope you are enjoying the quiz. So we are in the quarter stage of this. We have 7 more questions to go, right?
This is a leaderboard, sir. Siddharth and RXD and Kanav.
Okay, great.
Yeah.
So I think they are all students, I suppose. Yeah. So they have to write in after the quiz with their details. Okay. All the maybe first 5 or 6 or first 6 can you do that? Okay. Yeah. So let me go back. Let me just share the screen again. Question 3 is done.
Yes, sir. You can move on, sir.
Yeah, let me see whether it's visible. Is it coming screen? Screen is visible, Sham?
Yes, sir. It's visible, sir.
Okay, thank you. So question 4, 8-year-old girl with idiopathic CPP started on leuprolide depot 3.5 milligram monthly. After 6 months, breast regression is incomplete. Growth velocity is 9 centimeter per year. And we have done LH post stimulation. It is not suppressed. It is equal to 2.5 IU per L. Estradiol is also coming in the higher range, 45 picogram per ml. So what according to you is the best step? So first option, do you want to continue the same dose for 6 more months, hoping that the patient will respond? Or do you want to add aromatase inhibitor if you have found some other causes or maybe you want to try again? Or do you want to go for the C, increase the dose to 7.5 milligram or switch to 3 monthly depot? Or is it D, do you want to try with adding cyprotron acetate? So 30 seconds time for you to guess.
Sir, you can move on to the next questions.
Thank you. So question number 5. A 7-year-old boy shows pubic hair acne. Testicular volume is 5 ml. So it is started puberty. LH is, however, less than 0.2 IU per L. Testosterone level comes sky high, 800 nanogram per deciliter. DHEA is 50 microgram per deciliter. For that age, it's also high. HCG is 60 IU per L. What is the most likely etiology? So is it A, adrenal carcinoma? Is it B, Leydig cell tumor? Is it C, a testotoxicosis? Or is it D, HCG secreting germ cell tumor? So I am asking you most likely diagnosis. So you have to guess as per the clinical available data, 1, 2, 3 diagnosis, which one will be the first among the DDs? Just tell me when it is done. How many are there in the quiz now?
You have 63.
63, good.
You can move on, sir. Next question.
Thank you. So number 6, a 6-year-old boy, LH 0.4 IU per L, FSH 1.2 IU per L, testosterone 250 nanogram per deciliter, DHEA is 400 microgram per deciliter, 17-hydroxyprogesterone is 7 nanogram per ml. What will be the most likely diagnosis? Is it a non-classic CAH, option A? Is it likely to be a central precocious puberty? Option C, testotoxicosis. Or is it D, premature adrenarche? These are all today's topics only we discussed. So those who have enjoyed today's discussion, you will definitely be able to answer this question.
After this, we are supposed to show the leaderboard, sir.
Yes. This is the last time we'll show before the end, right?
Yes, sir.
So this is exactly the last time to catch up. So I'll stop sharing screen.
Yes, sir.
Thank you, Shyam. So let us see how many have tried to answer. Okay, great. So we have got Kanav, Krishnaveni, Manisha, Ayush, Bhavisha Desai, Manjunath. Okay. So remaining all trying to catch up. It's great. I think it's a very neck to neck. It's happening. So let us see how it goes next. So I'll share the screen. Is my screen visible? Let's tell me.
Yes, sir. Go on, sir.
Thank you, Shyam. So question number 7, a 6-year-old girl with McCune-Albright syndrome diagnosed. She has finding of a rising LH. That is a basal 1.2 IU per L and peak LH of 6.5 IU per L. After aromatase inhibition therapy, so there is still rising. Okay, so they have already given and now the values are not getting controlled. So what will be your next step? So is it A, would you consider malignancy in this case? Option B, do you want to add GnRH analog? Is it option C, do you want to switch to cyprotron acetate? Or is it option D, would you want to continue aromatase inhibitor, which is already been done with a higher dose? These are all evidence-based questions. These are all standard MCQs. So those who really want to know more, please, it's welcome to learn the guidelines. Really, I thank Dr. G. Srinagesh for having guided us.
So next question, sir.
Yes, thank you. So the 8th question, so you have got, is it 8th question? Yeah. So the 7-year-old boy with testotoxicosis fails cytotron acetate that means the LH value is still low and testosterone is still high. Which among the following, this is based on a global consensus guideline, or we can say two guidelines we have come back to back, that is endocrine reviews and ESPE guidelines. So which among the following has demonstrated most consistent improvement in the predicted adult height in boys with osteotoxicosis? So option A to D have been given. Is it medroxyprogesterone acetate plus cytotone acetate? Is it option B, GnRH agonist plus anastrozole? Is it bicalutamide plus anastrozole? That is option C. Is it option D, ketoconazole monotherapy? So option A is DHPA plus cytotone acetate. Option B is GnRH agonist plus anastrozole. Option C is bicalutamide plus anastrozole. Or option D, it is ketoconazole monotherapy.
Next question.
It's all difficult to be Googled, so it's all from guidelines. Okay. So 9th question, a girl with central precocious puberty treated with GnRH agonist. So already treatment has been started. So we are coming to the growth velocity. That is the growth velocity drop from 10 to 5.2 centimeter per year. So that means we are getting some static Chandler stage also. So what is interpretation of this? So do you want to consider oversuppression? Do you want to think it is appropriate? It is option B. Is it option C, incomplete suppression? Or do you want to add GH immediately? So you can answer A, B, C via your Mentimeter scan code. So next we'll have the last question. So maybe 10 seconds more.
I'll give you the clues. So next question, last.
Thank you. So last question, 10th question. According to the published Indian data, which among the risk factors is the key predictor for CNS etiology in your CPP? Is it a female sex? Is it onset less than 5 years of age? Is it a slow progression? Or is it option D, obesity? Are my options visible? There is some internet problem here. Can you see the options, Sham?
Yes, sir. Yes, sir.
Okay. We can give some more time here. Five seconds more. Okay, done. Sham, is it done? How many have answered totally?
1 second, sir.
Yeah.
I'll do the screen shares of the finals.
Yeah. So do you want to do that now, or do you want to? We'll just see how
We
it
can
is.
do that, and then you can do Q&As, the answers things, sir.
Okay. Fine. So I'll stop sharing the screen. Thank you everybody for listening. So this is actually one of the best opportunities I got to learn as well. Thank you, ESI, for this great opportunity as well. Thank you, Dr. Soumik, as well. Thank you, Sham, for the help. So I hope you liked the quiz. Okay, great. So we have got winners right here. So this is the final tally. Okay. So congratulations, Vishnaveni. You have to write to the ESI team, the email address, either to me or Dr. Soumik. Okay.
So first 6, right, sir?
I'm sharing my email address in the chat box.
Okay.
Is it visible to our student panelists as well, the chat box? Or the participants in the quiz, is it visible to them?
Yeah, so you can, I will just do that. You just share here on the chat box. I will share, I will see that. 1 second.
Yeah, we can share that on the screen share, sir.
Yeah, that's I'll do that. Let me see the chat. Okay. Yeah, you can share it on the chat box here in the Zoom, sir, so that I can put it on the chat box on the screen. Second person, who is second person? Okay, back.
I'll do this. I'll send you that thing.
Okay. So I did not announce the first 3, so there should not be any controversy anywhere. Soumik sir's email address will be shared on the screen. How was the quiz? I think Sahu sir is here, maybe Soumik sir is here. So I think it's a very interesting to have some student engagement also. Students are also out here.
Questions were little difficult, Mon.
Sir, I think coming from you, it's a compliment only. Okay. So actually the students
No, nowadays students is
yeah, sir.
nowadays students are more
improving,
knowledgeable,
sir.
so they should able to answer.
They are improving every day, sir. I think we are trying to catch up nowadays. Okay. So I have got Dr. Soumik's email with me. Okay. So I'm just putting it on the first screen now. So you can send your feedback also on this email. Okay. So let me just share the screen. Soumik, how was the quiz?
It was wonderful. In fact, I was a bit fortunate to see the questions a few hours beforehand because you had sent them to me and I found them to be very interesting and very
I just put in here.
Thought-provoking.
I just put in here. I'll just put in central mode also so that people who are not seeing it. Okay. Yeah. So I'll put it in the center as well so that you can all see that.
So the winners are requested to send in their details to this mail ID.
Yeah.
Within the next 24 to 48 hours at the most, because then we'll coordinate with the ESI central body to see that you get your awards as quickly as possible.
Yeah. So those who are visible, yeah, the email ID is displayed here. I'll make it full screen also. Can you see the email ID? dr.saumikgoswami@gmail.com. dr.soumikgoswami@gmail.com. Okay. Sham, shall I close the screen?
Yes, sir.
Okay, thank you. So the winners, once more, the names, please.
I have given you the name, sir, in your chat.
Okay, chat box, right? Okay, where in my personal WhatsApp?
Yes, sir.
Okay. So let me just read it out. Okay, the number one names according to this list is Krishnaveni, Dr. Krishnaveni. Congratulations. Institution name we are not aware. Second person is Bhavishya Desai. Again, congratulations to you. Third person is Dr. Kanav Khanna. He is from AIMS Jodhpur. Good, he has won. Number 4 is Dr. Manjunath. So we don't know which Manjunath. There are at least 4 in endocrinology as well. So I hit student Manjunath, I think. So the number 5 is Manisha and number 6 is Nikhil Sanjeev. I just put the names so that if there is anybody who is not qualified or maybe not eligible, we'll try to give to the next best person. Okay, thank you very much. So with this, do you want to know how the quiz went? Do we usually do that as well? The answers? Sham?
We can, sir, if time permits, but we are running out of time. So...
Yeah, that's what. If I think that's better to run fast, no? Answers.
So you can quickly give out the answers. Quickly.
Yes. Because I just open it up because I kept in different files so that even me will be blinded to the answers. Okay. So I'll just put it now. I'll just take 1 minute only. So let me see whether it is coming. Yeah, it's coming now. Screen is visible now, Sham? It's coming full screen?
Yes, sir.
Visible,
so
please go ahead.
I'll just go fast. So references are from these articles, which we have read through, just to the students who are for benefit. Okay, the first answer is C. Uterine length more than or equal to 3.5 to 4 centimeter. Your ovary volume is more than or equal to 2 centimeter cube. This radiology, we are supposed to go and inquire. That is the best way to do it, because don't go by according to age, it appears infantile, normal. That is not the way to do it. You should go and discuss. That's what my students also I used to tell. Option 2 is A. MRI is the indication for boys. Actually, if central precocious puberty less than 6 years, definitely you have indicated mandatory regardless of symptoms as per study. And option 3, the question 3 answer is B. We are seeing a discordant gonadotropin response in 6-year-old child. So you can see that the values rising estradiol confirms central axis. So it is actually early central activation, deepertic central only. Option 4, the answer is C. Pubertal progression despite GnRH analog therapy. Incomplete LH suppression indicates subtherapeutic growth. That means you increase the dose or switch the formulation, whichever is indicated in your case. So option 5, we had a rapidly virilizing child with high HCG. So increased elevated beta HCG causes gonadotropin independent testosterone production. So HCG tumors are the most likely possibility. The question 6, the answer is A. We are seeing an atypical hormone pattern, as in this case, elevated 11-hydroxyprogesterone indicates adrenal source, non-classic CH due to 21-hydroxylase deficiency. So answer is A. 7th question is actually a bit important because there is an overlap between the mecanoaldehyde child, overlap between peripheral and central activation. So we are definitely indicated to do a dual suppression with GnRH agonist. Then option 8, question 8, the option is C, which is correct. That is, we have to combine aromatase inhibition with bicalutamide, which will definitely help. That is what we definitely learned from this thing. So that is what we are getting the question. 9th question, the one is interpreting growth on GnRH therapy. The rationale for this, you see that it is stable condition. So it means adequate, it is HPG axis. We should not start GH therapy at this stage, at least till some more time will we get. The last question, the one which is seen Indian data from Anurag Bajpai et al. Published in 2002 itself, it showed that there is early onset in central precocious puberty in a male sex strongly predicts neurogenic CPP in Indian cohorts. So with this, we really thank you all for joining today. Over to Dr. Soumik Goswami for the remaining part of the discussions. Dr. Soumik? Maybe vote of thanks from you.
So I think we have had an excellent session, and again, our thanks to Dr. Sahu and his team, and all our students, and of course to you, Dr. Mohan, Dr. Shujoy Ghosh, the technical team who have done an excellent job of linking different parts of the country virtually. So with that, I think we should call it a day, and we look forward to the next case capsule. Keep your eyes on our website, on our sponsors, because we'll get back to you with the dates very soon. A very good night to all of you. Stay safe, stay healthy. We'll meet soon within a month's time. Thank you.
Thank you, sir.
Thank you.
Thank you, sir. Thank you, Soumik, sir. Thank you, technical team. Thank you, Lupin team. Thank you, students as well.